in a moment to Jeffrey Hayden Kay, who is going to join the MAPC program at Royal Roads in May. Jeff's a creative marketing and sponsorship coordinator at the Gian and Peter Lougheed Performing Arts Center in Camrose, and he's also a volunteer firefighter. And he lives in a small town in Ponoka, which is, again, in my old backyard growing up in central Alberta. So Jeff, I think you're in the room. If you want to come on camera and mic and introduce Dr. Clark, and we'll start the next session. Hi, Wayne, nice to see you.
Hey, everyone. It's great to be here. Thanks to Royal Roads for allowing me to volunteer. Before I introduce Dr. Wayne Clark, let me just do a quick land acknowledgement. As for Royal Roads, the campus is located on the traditional lands of the Esquimalt and Songhees ancestors and the families who have lived there for thousands of years. I should probably do a land acknowledgement for myself. I'm on Treaty 6. I'm about 10 minutes from Musquatchees. And so, yeah, that's my own also recognition of the area. So welcome, everyone. I'm really excited to introduce Dr. Wayne Clark and his session of cultural safety and anti-racism in health and social systems. He brings knowledge and understanding of the barriers that Canada's Indigenous peoples face. Dr. Clark is the Executive Director of Indigenous Health Initiatives at the University of Alberta's Faculty of Medicine and Dentistry, where he gets to work directly with medical students and guide them through understanding personal biases, as well as the cultural and systemic barriers affecting Indigenous peoples. Dr. Clark is passionate about this issue, and he explained to me that it not only relates to healthcare, but policies and law and education have precluded Indigenous communities from the first day settlers landed on Turtle Island. While the challenges are great, Dr. Clark is also excited to see younger generations of medical students committed to social justice with the goal of giving back to their communities. We're in for an excellent session, everybody. Excellent session of learning, and Dr. Clark encourages participants' questions to help us through this learning process. And speaking of personal learning, I'm just going to add this. I thought it was kind of funny. I thought it was so cool that Dr. Clark has syllabics in his name. So I was sending him an email. Oh, by the way, what does that mean? He said, well, yeah, no problem. He sent a great reply. He said, it means Wayne Clark. So, so for me, that was a great, I guess, personal life lesson, or a personal lesson about my own bias and just life lessons that we can all take from this. So without further ado, Dr. Wayne Clark, thank you so much, and look forward to hearing everything today.
Great. Thank you very much, Jeffrey. I just want to do a check. Can everybody hear me okay? Yeah, thumbs up. Good. Can you hear me? Okay, good. All right. So I'm going to start my presentation, which is cultural safety and anti-racism in health and social systems. I'm delighted to have this opportunity to be at the first annual conference on communication ethics. And I was very interested in coming and participating as an alumnus of the school, and I've been back a few times, but really excited to present on this topic, which is something that I've talked about with different organizations as they start to recognize this issue a little bit more in the past several years. So Ulakut, good day. I should also mention a little bit about myself. I'm originally from Churchill, Manitoba. I'm Inuk, and I'm part of the Kilavakut, which is Inuit from Kivalliq, and a beneficiary of the Nunavut Land Claim Agreement. I have worked in Indigenous health for the past 11 years, and prior to doing that, I had held communication roles in different Indigenous organizations or media companies. So I will just load my presentation here. And see if I can, I've got this, 1 second here. Okay, this should work. Okay, so the overview of the session, I'm going to talk a little bit about definitions because those are important to this discussion and the context to what I'll be getting at. It's important to also talk about who the Indigenous peoples of Canada are and the context in which healthcare is delivered to these groups can vary depending on the group or the location in which they are located, for example, on or off reserve. I'm going to talk about 3 very important cases in Canada and the implications that these cases have had to policy and the way in which we're moving forward. Those include Joyce Quechuan, Brian Sinclair, and Jordan River Anderson. I will touch on the truth and reconciliation calls to action in health and how those have made somewhat of a difference in terms of where we are currently at today and the conversation around racism. And then I'll follow that by discussing devolution of federal systems or systemic racism that's occurring as well, and show you some examples of that. And then, and then we'll talk about, how these can be addressed and partnerships. So first of all, I'd like to describe cultural safety. There's different definitions that are out there, but it was an approach that was conceived by a Maori nurse in the 1990s, and it's an approach that considers how the social and historical context, as well as structural and interpersonal power imbalances, can impact health and healthcare experiences. These can be, inclusive of social determinants of health, as well as the kind of cultural knowledge that a healthcare provider has. We also talk about, culturally safe environments, and in order for those to, be in place, the organization would need to have policies and practices that are culturally safe, and certainly training for new healthcare providers or new staff that join the organization. Although my intention is not to talk about that at an individual level today, cultural safety is something to consider if you have not heard of it before, or how cultural safety may impact systemic issues given the roles of individuals within systems. And then institutional racism, which is also referred to as systemic racism, is enacted in the form of requirements, conditions, policies, and processes that uphold and replicate inequities across racialized groups. Now, I should just add that there are implications for other racialized groups with this discussion, but I'm going to be focusing specifically on Indigenous peoples. And you're welcome to consider how this might impact others. I would just add that that is not my expertise, but there certainly is a movement to address those issues, as well as you've seen this year in the past with Black Lives Matter and other kinds of movements that are taking place. Okay, so there are currently, okay, just a sec. Okay, good. Okay, there are currently over 1,673,000 Indigenous peoples in Canada. So this represents almost 5% of the population. And of that total population, 977,000 are First Nations, 587,000 are Métis, and 68,000 are Inuit. And Indigenous people in Canada are comprised of these three groups, which are culturally distinct and recognized by the Constitution Act of 1982. In the next 2 decades, this total population is expected to exceed 2.5 million. And this relationship with Indigenous peoples in Canada was first acknowledged in the British, in terms of laws, acknowledged in the British North America Act of 1867. Now the Constitution Act. There was additional legislation that occurred after this, which includes the Indian Act. I'm not going to get into the Indian Act today, but it's a very important aspect of systemic racism, and we'll talk a little bit about that. But I'm not going to get into the actual statutes of the Indian Act. But the one thing that's very distinct about the British North America Act is that it acknowledged that the federal government was given responsibility for Indians and lands reserved for Indians, while provincial and territorial governments were given the responsibility for both health and education off reserve. Now, that is an important element of this talk, because the jurisdictional issues that occur are those that are probably the most challenging to a system that works this way. There are no other groups within Canada where this applies. So to give you an example of that, there is limited resources of healthcare available on reserve or in Inuit communities. And for any tertiary or specialty care, those individuals or those patients would need to go to an urban center. And of course, that would be then the oversight of the jurisdiction that those facilities are in, or where those providers work. There are some exceptions to that, which I'm going to talk about as well. But this goes back a very long ways in our history. And that continues to play out not only today, but for the last 150 years in terms of how the healthcare system was designed, and how policies and practices within the system have upheld this jurisdictional dichotomy. So First Nations is one of these groups, and they are the tribally and linguistically diverse peoples who are considered First Nations within Canada. And I would say that often, which is the largest group, but where the legislation was written to describe Indians as status or registered Indians under the Federal Indian Act. And a status Indian is recognized as either a 6'1" or 6'2" Indian according to this legislation. And this is really important because there can be registered First Nations or Indians within a specific community that are basically, this would be considered a treaty Indian or a registered Indian. And depending on the way in which a 6.1 and a 6.2 are categorized, they're not able to always pass on their Indian status to their children. This was rectified in the 1980s with Bill C-31, which had to do with the rights of Indigenous women, because earlier on, when an Indigenous woman married a non-Indigenous man, she lost her status. So there's a whole lot of non-status Indians that live in the country that wouldn't necessarily be considered Métis, which is another group that I'll speak to in just a moment. That plays a role in how healthcare might be offered. There is also a specific First Nation has a right to identify who their band members are. So that gives them a little more authority to give membership to somebody that might fall outside of the 6.1 or 6.2 category. And in which case they can potentially obtain services. And as I mentioned, there are some limited services on reserve, but the remainder of care is offered by the provinces or territories. The type of services that are offered are the bare minimum. Depending on the size of the First Nation, they are able to negotiate the kinds of funding that they would receive for the types of care facilities that they can offer, or the care providers that they can hire to work in their communities. So if there is a large First Nation that is accessible to urban centers or where care providers live, they may have some better services within those communities, and also more funding for bringing in locums or temporary physicians, agency nurses, and the like. But often the community is basically having a nursing station, which can be a relatively small 2-room building with a nurse or two that would be responsible for all of the care in the community, and they would order medivacs for individuals in cases of an emergency, or make referrals to physicians or other clinical services within the I guess the city or the closest area. And often within provinces, this requires a significant amount of logistical travel arrangements, which are, because if you're not always coming on a medivac, then there are travel arrangements that are made, and there's regular flights that would take patients, in and out of the community, and in boarding homes and other accommodations that would be in place in the urban centers. And the logistics around that are significant. If a individual First Nation person is living in an area where there wouldn't be flights in and out, then they're often taking the bus or responsible for their own transportation. And there's certainly been instances of elderly people having to take buses to the city and being on bus rides while being very ill or frail for 8 to 12 hours. Inuit, because of the geographic geographic disparity among the communities in the north. We're talking about 40% of Canada's landmass. There are 4 Inuit-specific communities that have, or regions, I should say, that have land claim agreements. And that includes the Inuvialuit region, which is, western, just in the western part of the Northwest Territories, Nunavut, which is the largest territory, Nunavik, which is northern Quebec, and Nunatsiavut, which is Labrador. And these distinct locations have certainly their own dialects and own culture and histories, but they also have different relationships with the system because of the geography. So depending on where you're located, you may be sent to Montreal, to St. John's, Newfoundland, or to Edmonton or to Winnipeg, generally as a rule. And this can vary for mental health services as well, and addiction medicine as well. So the kinds of services that are available in these regions are also varied. There's a very diverse healthcare delivery context if you are in a small remote community on Baffin Island, or if you're in the capital of Iqaluit, you will have more support within a hospital that exists at Iqaluit, but the support that is available there is minimal. So typically for any kind of surgery, you would have to be sent to the south. And then as far as primary care goes, there are locums that will be in most of the larger hamlets or communities in Nunavut. So there is some progress that's being made in that regard. But ultimately, a lot of the clinical services are offered in the south. I should add that there are no dialysis services in the north, and there's very limited kinds of diagnostic equipment. For example, when we've heard about COVID-19, respirators are just not really all that plentiful in these locations. So that's one of the reasons why there was such concern for Inuit to stay, with really low counts as much as possible. And to some extent, we've been successful in that regard, except in the community of Arviat, where cases continue to mount, and the virus was brought in from a patient who came to the south. It was traced back to Winnipeg. So in terms of that federal responsibility that I mentioned earlier, there is a clause in the Indian Act that the federal government assumes the same responsibility for Inuit as if they were registered Indians, although legally, I think that's the only reference to that. So in terms of the health delivery model that looks at sort of, that relationship for off reserve or relationship with services that are in other parts outside reserve or land claim regions, that is exactly what occurs. There's also, health services that are non-insured, which are also covered by the federal government for Inuit, First Nations and Inuit, but they're also somewhat limited, and their budgets have not increased, even though the population has increased significantly, particularly over the last 20 years or so. And of course, what what I mentioned about the growing population. So for the non-insured benefits like pharmaceuticals, dentistry, and so forth, there are limitations on that as well. We also have to look at sort of the different contexts too, because these are federal programs that are targeted at both groups. And Inuit do not follow the same, traditional healing practices as First Nations. So the way in which these programs are designed need to be respectful of the two groups, but yet they tend to fall within the same, context in terms of what's available. So there is some discretion that the federal government has. I think they try to be equitable, but I would say that that's been one challenge, just given the population size of Inuit compared to First Nations. Now, in relation to Métis, I mentioned that Métis are one of the 3 recognized groups under the Constitution Act. The difference here is the federal government does not have responsibility for Métis health and education like the other 2 groups. And so Métis are individuals of mixed First Nations and European ancestry. Usually the groups of men that came over to work in the fur trade and had a long history. Communities began to grow and they were definitely Indigenous groups, Indigenous populations that were forming. But after the Indian Act was established, they were either I guess at that time asked to go and be part of the First Nation or stay as their own communities. And so they ended up becoming sort of lost in the focus on the way programs and services were designed, because the federal government did not claim any responsibility for them. And at the same time, the provinces were also not necessarily upholding their responsibilities to them, particularly the province of Manitoba and Saskatchewan. They do have their own, histories and culture, and certainly ways of knowing and wellness that would, contribute to their health and well-being. There has been some recent rulings. The Daniels decision classified non-status Indians and Métis also as Indians under Section 9 or under the Constitution Act, but it has very limited reach. And so the way or how, what the implications of this ruling will be still will remain before the courts. And I think it will take some time for that to be fully rectified. Really, like, if at all. There's been some challenges with the Métis groups for some time, and that is why they've organized in the way they have in the last 30 or 40 years. I would stay on top of that. But the one thing with Métis is that they're often left out of federal programs, right? And in turn, provincial programs, because provinces may not necessarily want to distinctly acknowledge this group, and the same as non-status Indians. But what could happen is you see the sort of pan-Indigenous kinds of programs, and in those scenarios, Métis would be able to or eligible for those, depending on the program. And this is, so with this kind of complexity around, these classifications, it's often important in the healthcare system for somebody to, be able to navigate through a lot of this and advocate for an Indigenous person's rights in relation to the service delivery or the service needs that they require. So most recently, one of the most, I guess, one of the tragic cases that we've heard about was Joyce Quechuan. Joyce Quechuan was a woman that attended a hospital in Montreal and filmed her death using her iPhone, and it was posted to Facebook Live. And this was a scenario where there was, overt racism being directed at her by two healthcare staff, and she died under their care in this Montreal hospital. I guess the awareness of this video created quite an uproar, not only among Indigenous communities, but government and academics, as well as the general public, recognizing that the Truth and Reconciliation Commission of Canada had been out for the calls to action, and its final report had been out now for about 5 years at this point in time. And there was some significant work taking place in this area, but this was really demonstrating the fact that racism still persists in everywhere in Canada. We were starting to talk about racism, with the Brian Sinclair inquest that occurred in Manitoba, but it was still like the R word was not always really, people weren't ready to hear it all the time. And I think with the Quechuan case, it really brought out the fact that racism still exists. And although I'm speaking about systemic racism today, the fact that racism still occurs is directly due to the fact that systems have not necessarily caught up to date with the views of individuals that feel that there's more work to be done. Systems take a much longer time to be addressed and to be undone. With Joyce's principle, this is a protocol that was established by the Atacamaku Nation, and it demands that Indigenous people have an equal right to the highest standard of physical and mental health, with right to traditional medicines and the conservation of vital medicine, plants, animals, and minerals. There's more to it than that, but I'm raising this because it's important to the conversation, because the federal government then took it upon itself to have, anti-racism roundtables with the Indigenous peoples of each province, which were taking place in January and February of this year. And they're continuing to talk to groups such as the Indigenous Physicians Association of Canada, the Indigenous Nurses Association of Canada, as well as First Nations, Inuit, and Métis groups across the country. Joyce's principle is something that has driven this work. And they started to look at systemic racism and just the fact that, okay, where are we now with cultural safety training? Cultural safety training was sort of the beginning of the TRC calls to action, but that specific training really looks at, the history, the distinctiveness, culture, power imbalances of individual healthcare providers. It doesn't delve into the issues around policies and systems. Although I think it touches on systemic racism, or some of those trainings do, but one of the things that is really important to that conversation is that a lot of the non-Indigenous healthcare providers that take the training become knowledgeable of the culture and history and the Indian Act and things like that. But it's so, different than the clinical training that they've received that they may not necessarily know or will be able to do on their own to consider how they might be able to change their clinical practice. So for example, an assessment form, I often use this example because the Quechuan tribes in British Columbia looked at a mental health assessment that can be done quite quickly. It's got, I think, about 30 questions or so. And on this, this assessment, there's pictures of different flowers or plants and animals and other kinds of questions that are really targeted at a mainstream audience. So for example, I think it's got a hippopotamus as a picture. Well, an elder from a First Nation community may not have ever seen a hippopotamus before. So they wouldn't be able to answer that question. So that would potentially score them a lower result out of 30. And that's an important test because it could potentially lead to other tests that look at competency, and cognitive ability. So Joyce's principle is ongoing, and it's been, I think, the first real national attempt in a while to do something about racism and systemic racism. The Brian Sinclair case was one that occurred in Winnipeg in 2010, I believe, or 2009. And what happened with Mr. Sinclair was he was in a Winnipeg emergency department waiting room for 36 or so hours and was not given any care at all. And he was, in different locations in the waiting room, and he eventually was found deceased in a hallway, leading to a stairwell. And with that death, there was a lot of, passing of the buck by different staff that were working in the department at the time, as well as between the parts of the system that were responsible for him. So there were issues of communication between his home care staff, which is one part of the system, the community health, his primary care providers, which is another part of the system, the emergency department, which is another part of the system, and the provincial guardian trustee office, the PGT office, which is another part of the system. And so when someone has an order of PGT, they should be flagged so that we need to, as healthcare providers, call in one of those alternate decision makers for an individual who is not able to make their own decisions. So that didn't occur either, right? And when Mr. Sinclair passed away, there wasn't an acknowledgement that he was treated this way because there was overt racism, right? In terms of why he had to wait, and they basically just ignored him, right? And pretended he wasn't there, like he was almost invisible. There's actual video footage of him sort of moving from place to place within the ED that was done after, and you can just watch him disappear. And it is quite tragic in terms of the inquest that occurred. There was some acknowledgement of racism, but it was I don't think the system was ready to start having conversations about racism yet. And so what the government, the provincial government of Manitoba agreed to do, and how how the inquest was enacted, I think were probably, could have been a little more serious, if that might have happened later, right? Because now we know that racism exists and people talk about it openly. 10 years ago, when I was in a different role in the healthcare system, I would hear people talk about racism, like some physicians, Dr. Barry Lavallee, he would mention racism, and people would just cringe. Like, it was like saying the R word. Today, now we're talking about it quite openly. With some of the other scenarios that we've heard about in the media with racism, I think we recognize that it is a big and real problem, and we're now starting to deal with that. So I think that, Mr. Sinclair did not die in vain, and this was one of the most important cases to looking at this. The other thing that I think it's important to recognize is that I mentioned about the systems, the different delivery agents that I spoke about. They were not talking to each other. And it raises a concern about, how health information for Indigenous people is processed and how it's shared. And I think that is something that we're continuing to look at, but there is a gap in how that is achieved. And then Jordan River Anderson, which is a very tragic case. This case also resulted in Jordan's principle, which ensures that First Nations children can access the services they need, regardless of where they are, and that this can be culturally based services, as well as any other kind of service that may not be available on a First Nation reserve. Because what happened with this case was Jordan River Anderson died in hospital while the federal and provincial governments fought over who was going to pay for his care. It's quite tragic. It's been said that he died of a broken heart because he never had a Christmas at home. He basically lived, in the hospital for most of his life. So he had limited access to his family. And others in his community, right? When he passed away, there was a movement to ensure that this wouldn't happen again. And now Jordan's principle is in place, and the federal government has ensured supports for children with disabilities and special needs in communities, so that they can access those services without having to leave the community. This has been a landmark case because it's shifted the way services are provided. We now have coordinators in these communities who work on these kinds of cases now. And this includes, children with autism, children with physical disabilities, children who require a speech language pathologist. I mean, the list goes on. And there's also an educational component to this as well. Of course, there are still supports that cannot be offered on a First Nation. So there are Jordan's principle service coordination between institutions off reserve, so that there can be more supports for families to be able to have respite in their community, or that sort of thing. So this case, I think, really opened the door to recognize the jurisdictional issues that do exist. The challenge, I think, with this scenario right now is that it's for children under the age of 18. And we still see these significant gaps for persons with disabilities, like adults. And that is something that continues to be looked at. So moving on, the Truth and Reconciliation Commission of Canada was, of course, the huge review that looked at the legacy of the residential school system and the genocidal policies and practices of the federal government, particularly with the history of the residential schools. But it also looked at a lot of other policies that looked at, how Indigenous people were impacted by these. Because it was one thing to go to a residential school, but when you came out of that residential school, what you then had to face was, very challenging for those individuals who were taken out of their communities. And when they went back to their communities, they were sometimes ostracized because they were seen as different. So there was a significant amount of challenges associated with this that stemmed right across society. And the fact that these were allowed to begin with really looked at sort of what were the overall policies that existed in Canada when these schools existed. And so it's I think, important to recognize that there's calls to action that look at sort of the legacy of what the systems were in place when residential schools were established, but also looking at how it breaks down into education, health, justice, and other sectors. So in the healthcare context, there was recognition that Indigenous people have distinct health needs that should be understood and addressed. So if you consider something like historic trauma, because Indigenous people that had gone to residential schools or were related to somebody who went to a residential school and had significant mental health as a result that was untreated and then perpetuated in families, there's that could be, for example, one of the reasons why the mental health is what it is within these communities today. And there is really very limited amounts of health services to support that. Or that when someone is consistently trying to get help, but the system refuses to care for that individual because they think that they're incompliant or something like that, because they're still struggling, right? And there needs to be better services designed to recognize, just to at least recognize that their histories might be, or there may be some play a role in where they're currently at with their health. And then, just to mention, like, the calls to action need to be recognized not only by people that work with, in social services or health services, but society as a whole, I think, needs to understand this so that it can be easier for programs to exist. Programs are funded by government, and if there's no political will to support Indigenous people, then you'll continue to see these issues continue to come out in the foray. So I think the discussion of reconciliation is important to everybody, but how it breaks down in the healthcare system is really important, because if we look at the policies and the systemic aspects of that would be, there's reconciliation required there as well. It's not just reconciliation with Indigenous people. We have to reconcile the systems that have been designed to racially segregate into Indigenous people. So then that gets into more of the topic of systemic racism that is what I wanted to also drive here today. It's created one of the most significant barriers. I think, individual racism, even at the unconscious bias, that will happen at the individual level. But, when we think about, policies or the environment in which these issues are taking place in, that's where you see, like, for example, a nurse might say, I really want to help him, but I don't know how I can, because the system just doesn't let her work with this patient. And the patient may not live in Winnipeg. So if the patient, or sorry, in a city, I'm currently in Winnipeg right now, it may be going back to their community. And as soon as they go back to the community, she's no longer responsible. Like she's not working for the health authority that can provide care to that individual. So it's very challenging to then create a care plan that exists between a provincial facility and a federal facility. So that continues to be an issue. Not impossible, but those healthcare providers really have to go out of their way to make that happen, because the system doesn't allow that to occur, within its, kind of normal operating procedures. And that's why there's advocates, Indigenous advocates or Indigenous health specialists that do that coordination. Unfortunately, there isn't a lot of those in the system. If you could imagine this growing population, and there's maybe one or two per region, like per city kind of thing. And then when we consider like systemic racism and that legacy of racial segregation that continues to exist today, that affects the way individuals are treated. So if someone doesn't necessarily go out of their way because they know the system and provide a care plan for someone, the individual patient is certainly not going to know how to do that. And so they often stay silent. One of the other things that occurs quite too frequently is they don't have a lot of faith in the system because it's never really given them a lot of care. If someone has been treated differently because of their race, the chances of them having any kind of trust with the system is likely not going to happen, right? So we need to consider the structures in which healthcare is delivered. So, considering this, we need education, because if there are no ways to change the system, we need to educate people that have the ability to do that. And so that, could be seen as cultural safety education. That's what we currently have available, but I think we need more than that, that looks at what we're talking about today and almost looks at sort of, the system as a, something that requires a transformative kind of overhaul, given the complexities that, if you consider the logistics, for example, that are involved, that can be, some of these things can be certainly improved. Recognizing we're not going to have hospitals in the north, that's likely not going to happen, but we can look at better kinds of telemedicine, or just having better treatment plans that are sort of cognizant of people's geographies and their need to travel. And then we look at decolonization, and decolonization would not only look at power imbalances, but they would also recognize the distinct cultures and histories and needs in a manner that's unique. So rather than thinking, okay, we need to change the system to be more responsive to remote and isolated communities, which I think just in a general system that would have its own challenges. But then within that, you may have Indigenous ways of knowing, right? That may look at how treatment is accessed. And there's lots of examples of that. But often when we go through, business processes of looking at quality improvement of systems, we don't necessarily think about, well, is that going to work for this group of people, right? And I think that, advertisers certainly know that when they, do advertising for, people in Quebec, right? So it would certainly be something that should be looked at when we look at system transformation for Indigenous communities as well. That requires expertise and knowledge, and it requires people that have firsthand delivery, knowledge of delivery, healthcare delivery in those communities in order to drive that. And then, lastly, it's kind of looking at, how those knowledges can improve the quality of care that gets offered there. So when we start to address, system challenges or system change, the federal government established the Department of Indigenous Services Canada to design new services that are going to be controlled and led by Indigenous peoples, for Indigenous peoples. This was a significant change that has occurred under the Trudeau government, where you've broken up, the Health Canada to have this separate arm that's also unique from the arm that's related to, Crown Indigenous Affairs and Crown Affairs, that's more on the legislative side. And this would look at all the services that need to be offered in communities. And so essentially we're looking at devolution, and the budgets that would have been previously held by federal government departments for providing care, they're then in turn, working with communities to be self-determining and, planning their own health services, and being able to then, hire their own staff, build capacity, build an infrastructure to do that. So this is a relatively new initiative of the federal government. But in order to achieve this, we need to ensure that the provinces can then work with communities to, have, a system or systems that are integrated in a manner that would be compatible. And I think that's the next piece of this work. I haven't seen it really unfold too much, although in British Columbia, there's the First Nations Health Authority of BC, which was established, I guess, about 10 years ago, and went into full operations shortly thereafter. It's been a few years now. And so they've been able to really test the waters a bit in terms of how this devolution process is going to look and what self-governance over or self-determination over health is going to look like. And it's different in every province. In BC, there aren't treaties like there are in other parts of Canada. And so it was perhaps easier to do out of the gate in those days. There's been, like in Nova Scotia, where you have 4 First Nations and that with their own systems in place and a smaller healthcare system overall, they've been able to achieve this as well in that region. And I think depending on, Ontario is going to be huge to do that, so will Quebec. I should also mention Quebec did not acknowledge Joyce's principle when it was, reviewed by governments. I believe, the federal government has got behind it, but I think provinces have not got there yet. So when I talk about provinces playing a role, it's very important for them to recognize this. And a lot of times there's been, the views or the attitudes by provincial policymakers that's not our problem, they're federal government responsibility, right? But they're all too ready to accept the transfer payments for the patients that get seen in their hospitals. And these mount in the millions because there's sometimes up to 30 or 40% of patient populations or patients within that are getting care within hospitals are from Indigenous communities. And then in terms of partnerships, there's, just looking at the time, I've got just a couple more slides here. in terms of partnerships, this is what's going to be important for, you know, how we move forward. You know, partnerships will lead to, you know, progressive programming that will be not only equitable, but fit, you know, the needs of those populations. And I say those populations because of the diversity that exists even within a province. So these need to be designed provincially, jurisdictional wise, but recognizing that, you know, the First Nation communities in the north may not have the same needs as the First Nation communities in the south. Different languages, different practices, different demographics, that sort of thing. And so partnership frameworks need to be put in place to help problem solve and move forward. Like, so really true partnerships that are looking at, you know, solving the same issues and, you know, taking action on priorities. You know, these can advance planning processes and like, for example, in quality improvement, as well as you know, how to communicate and coordinate resources with communities. So really considering change management plans that are going to be recognizing communication strategies that would be translatable at different, you know, to different audiences. For example, women's health might require something specific. Parents that have children with disabilities, you know, et cetera, et cetera. So there's, you know, there's layers in how this is going to work. You know, healthcare is only important when you need it. And so it has to be something that's, you know, it's not something that's shelved. You're constantly having to develop strategies. And it's not just the, you know, communication vehicles that are designed for, you know, for campaigns. It's day-to-day communication that occurs and what that looks like on an ongoing basis. And so, you know, because this is about ethics, and I hope that you got a sense of the ethical issues I discussed today, I want to end this with just restating that, you know, Indigenous groups are, many are signatories to treaties that were established, you know, well before Canada became a country, to the federal treaties, you know, treaties 1, you know, through XYZ, land claim agreements, and other partnerships that were set forth on these lands as relationships started at that time. And I think sometimes we've forgotten about those as a country. And so the need to recognize the need to change our system so that we can make good on the past and make the lives better for Indigenous people is where we need to go. And I'll leave it there, stop talking, and be glad to answer anyone's questions.
Yeah, hey everyone, and Dr. Wayne Clark, thank you so much. Yes, folks, please ask some questions. We did have a couple comments that I can either read to you, or you're welcome to scroll through. What's best for you?
Maybe if you just read through, yeah, I'll just catch my breath.
Yeah. Well, we all need breath. I agree with that. Let's see here. And yes, thank you everybody for sticking around. This was some of these observations from Dr. Clark really hit home, at least just in terms of, you know, my understandings and my own biases. So we have a comment from Natalie Allard. The statistics are inaccurate. It does not include those that self-identify. The Indian Act is still intended for forced assimilation because of the two categories. So I believe it's like section 6.1 and 6.2. She says, so my mom was 6.1, married a Frenchman, non-status, and had me. So I became a 6.1. So if I have children with non-status Indian, quote unquote Indian, my children would not have status. Oh, as she clarified, sorry, 6.2. So she said funding is always very limited with a lot of restrictions, usually can only be used for on-reserve registered status Indians.
So is there a question?
There isn't a question, just kind of a general comment, and obviously feel free to jump in on that. Or
well, one of the things that I wanted to raise about 6.1 and 6.2 status is just that formula is so outdated. And it's also an example of, how that's perpetuated in our systems, because Indigenous people, particularly Inuit and Métis, or Inuit and First Nation rather, we have registries for. There's no registries for other groups of Canadians. And so that is one of those, we're obviously a very racialized group. And I think the issue that I wanted to make with that is that that's also been like the process that has been used to segregate Indigenous people was looked at by South Africa when they were establishing apartheid. And so that 6.1, 6.2 legislation is really outdated. So, and it's been, argued before the courts many times.
Thank you for that. Yeah, Natalie actually had a couple more comments. I think when you were discussing about systemic racism in health, she talks about, she said, this still hurts me quite deeply. Racism is still prominent, especially in healthcare. I even got used to doing the buddy system here because our word is never taken seriously. That cannot be done now with COVID, so we are left even more vulnerable. She did point out also that intergenerational trauma is very alive and still real. These are, talking about the history. She also, if you look at the comments, Dr. Rain, and with everyone else, she did post a great resource on Vimeo. It's a link, reconciliation in the age of reconciliation. Now I opened up the link. Christopher was the keynote, and of course I closed the link because, why would I? Christopher Horse Thief, he was the keynote.
Okay.
So if you get a chance, everyone, I guess it was in 2018.
That's great. Thank you for that.
Yeah, and D. Russell, we had a COVID cluster on our reserve. My dentist in our neighboring city canceled my appointment without applying the health screening processes. When I asked why, they indicated they had to do what they could to protect their patients. It was clearly discriminatory practice, but I can't even complain because then I'll lose my family dentist. We can't even talk about treatment inequity with practitioners. A lot of these are comments, but feel free to add your own comments, Dr. Wayne, or Natalie Allard also, when she kind of jumped in just about her link, I think she said her favorite quote from that keynote was, "You can interact with other cultures without a way of trying to destroy them." May Shihade, can you please explain the last quote? So some discussions there. We do have a question. Okay, there's a transcript. Michelle James, is there any recommended resources for helping to educate frontline healthcare providers within the system?
Yeah, so there's the SANYAS cultural safety training. It can be found at sanyas.ca, and that is SANYAS. And that was specifically created for BC healthcare providers. And it's been customized for different parts of Canada. So I think they've customized that for Manitoba and Ontario. I think there's probably about 12 cultural safety training courses across the country. There's the massive online course that was, I think, recently promoted by Dan Levy. That education was designed by Dr. Tracy Bear of the University of Alberta. So that's also a good one to look at as well.
Sorry, I was just typing that in, trying to get the link to the massive online course. I'll try to get that to everyone unless someone else can grab it. Does anyone else have any questions for Dr. Wayne Clark? Glenda looks like she's grabbing the link. I think we're done here. For me, great learning. Hopefully for everyone else. So really good stuff here. Let me get you that link, guys. Let me just pull it up. Glendora grabbed it. Thank you, Glendora. 1 second, everybody. So if you're ever wondering, guys, Dr. Wayne Clark's, the syllabics are actually Wayne Clark. So that's always good. Thank you very much. I guess I'm going to let myself stop my video and my recording and have Chase jump on, or whoever else needs to jump on here.
Thanks, Jeff, and thanks, Wayne. Really powerful and important work that you presented, and ideas that you presented, and a history there. And really appreciate the time that you took out of your busy day and busy schedule to come and speak to all of us here today. So please stay safe, and thanks again for coming.
Thanks, Dr. Remelo.